All right. Well, let's jump in. I think we'll have a few more people probably jump in as we're moving along, but we'll get started. Going to jump back into some phobia stuff. But before we do that, anybody have any questions about material we've covered up to this point? Where we're at in terms of research or quizzes or grades or anything along those lines? Feeling pretty good about this? Okay. Good. All right. Well, to jump back into where we were last time, we finished talking about some phobias. Okay. And so here we're talking about specific phobia where the focus of the fear, remember, is going to be on some targeted situation or object, right? Looking at some different subtypes. We talk about animal subtype, natural environment, blood injection, situational type, and then this other is kind of a catch-all for things like choking, vomiting, sort of illness-related stuff, things like that. Okay. So covered specific. Any questions on specific phobia?
So, evolutionarily speaking, we are like prone to avoiding like dangerous animals, but would it really be considered like a phobia if like we're not always like afraid of snakes or like always afraid of bears? So like, what would you call it if it's not like if we're not like worried about it all the time?
Yeah. No, that's a good question, Colin. That's called a reasonable fear, right? One of the criterion for a specific phobia is that whatever it is that this causes that the fear is unreasonable or unnecessary, and that it exposure to this thing almost always results in sort of this intense or sort of fear-based reaction. So if sometimes spiders freak me out, but sometimes they don't, or sometimes I'm nervous about dogs, but sometimes I'm not, we would start to question whether or not that would meet threshold for phobia, right? When I'm asking people about this, a lot of times it'd be like, oh, are you bothered with heights? People are like, well, I don't want to hang off the Empire State Building. And I'd be like, well, good. Like, you shouldn't. That's not a good thing to do, right? That would be a reasonable fear. Or I'm afraid of bears in that, like, if I saw a bear, I wouldn't want to get mauled. That seems reasonable. But if, let's say, you were afraid of bears and you refuse to go any hiking on like greenbelt trails or take walks in any kind of wooded areas because of your fear of bears, then that would probably be a problem, right? Like there's no bears at Vita Vu or in the Snowies or things along, right? So it's this type of thing that will start to cause problems. Or, I can be afraid of snakes, right? But if I refuse to walk through, say, knee-deep grass because I'm afraid I'm going to get bit by a snake, even if it's not a place where snakes are, and I start to restrict my behavior in ways to avoid anything where I can't see all of the ground all the time, then that would start to look more like something like a phobia. Does that help, Colin? Okay. All right. So, other type of phobia that we're going to talk about outside of specific phobia, looks like it kind of has some of its features of its own: social phobia. Okay. Social phobia or social anxiety disorder is identified as significant anxiety for individuals exposed to certain type of social or performance situations. Okay, so again, we're talking about the focus of fear with our anxiety disorders. Focus of fear with social phobia or social anxiety disorder is going to be social evaluation. Okay, my concern with going into a situation is that someone will think badly of me or judge me, or that I'm going to do something to embarrass myself and other people. And what we see is this concern starts to restrict your ability to go through and do things, right? Maybe I change my major because my major requires a public speaking class. And so instead of doing what I want to do with my life and career, I change it to avoid this public speaking class, right? Or I can't talk to my professors because I'm too anxious. If I have a question, I can't ask it in class because I would rather fail an exam or get stuff wrong than sort of go through and ask a question because someone might go through and think something bad about me or evaluate me. Okay. Social anxiety disorder, third most common psychological disorder in terms of lifetime prevalence. Lifetime prevalence estimated about 13%. So this is again saying that about 13% of individuals in the U.S. will likely meet social criteria for social anxiety disorder at some point in their lifetime. Okay. What we see with individuals with social anxiety tend to be hypersensitive to criticism or anything that could be construed as negative feedback. People tend to have poor self-esteem, struggle with that. A lot of difficulties with assertiveness. Also see quite a bit of comorbidity with problematic alcohol use. Why might that be?
Because the sober version of themselves has a harder time than their drunk self.
Exactly, right? You know what helps me feel a little less anxious? Have a couple drinks in me, right? You get a couple drinks, then I'm able to go through and I'm interact and I'm able to go through and sort of talk with people, right? Now, from a biochemical standpoint, you learn this in drugs and behavior. Alcohol works on the exact same receptors and pathways as Xanax, right? So some people will get like a benzo or some sort of thing to go through and sort of manage my anxiety, or I can just have a drink, glass of wine, something like that. It's working the exact same way. But what happens is some people will self-medicate with this, and we can have a discussion whether benzodiazepines are any different than alcohol use. We say one's a problem, the other one's not. But at the end of the day, what we see is individuals with social anxiety disorder often will have, or will not uncommonly have, difficulties with drinking, just because this is how I manage to make my way through the day and manage some of that anxiety. Also see that individuals with social anxiety disorder tend to be employed, are underemployed, right? So they're not working up to their full level of qualifications, and also reporting low levels of social support. Why might this be?
They don't seek the support, as far as they can't reach out to people because of that anxiety. Therefore, socially, they don't have the same structure that an average person would have.
Yeah, no, absolutely, Hannah. If my biggest concern, the thing that terrifies me the most, is that someone could think badly about me, or I might do something to embarrass myself, reaching out and sort of making friends starts to become very difficult. Why do we see people who with social anxiety tend to be underemployed?
They would want to avoid job interviews or anything like it.
Yep. I've got my PhD, but I'm working as in a mailroom somewhere, right, where I don't have to interact with anybody. I could go up. I'm able to go up. I'm underqualified. I could go through and achieve and sort of get a better job and sort of get higher pay and things like that. But that would mean, one, I would have to interact with people, or two, that I would have to apply and maybe interview, things along those lines. Combination of low self-esteem, sort of not wanting to interact, fear of being around people, starts to result in chronic underemployment among individuals who's struggling with difficulties with social anxiety. Okay, so this is a lot, and this is one of those ones, again, probably most of us would be uncomfortable just walking into a room where I don't know anybody and introducing myself and say, hey, everybody look at me, or so I'm going to go through and do things, or standing up in front of a bunch of people giving an impromptu speech. That's going to be anxiety provoking for most people. But where we start to run into problems is we see people who will avoid introducing themselves to other people, talking to people in authority, people having problems eating in public, right? Because what if someone sees me eating? What if I do something embarrassing? I have a hard time sort of going to grocery stores, or will avoid things, right? That's where we start to see problems with clinically significant impairment coming on with social anxiety. Okay. But again, thinking about this as a continuum. Questions on social anxiety?
Yeah, I have a question.
Yeah.
Is like social anxiety like more prevalent in women or men, like specifically, or is it all pretty even across the board?
I would have to check with social anxiety. I think social anxiety is pretty even, Steven. In general, women tend to be at higher risk for mood and anxiety disorders. So depression, sort of a lot of different anxiety things. Social anxiety, I don't know. Cameron, can you send me an email? Because that's
for sure. Yeah. I just feel like I know a lot more females who like kind of like talk about stuff and they're like, oh man.
Yeah. I think in general, women tend to be sort of at higher risk for reasons that we don't completely understand. But I think social anxiety may be pretty even, Stephen. But yeah, email me and remind me to check on that. Good question.
Cool. Yeah.
Other questions about social anxiety?
Would public speech be considered a social phobia versus a specific phobia?
Yeah. If I'm afraid, and so this is the interesting thing, and prognosis for social phobia is generally worse if it's generalized, right? If I'm afraid of, and I avoid a lot of different situations that could incorporate social evaluation, impairment is generally higher, but we can still have people who are specifically their social concerns are very specified to one situation, and public speaking can be one of them, right? Well, if I'm just living my life a normal person, that maybe won't be an issue, right? But if I'm someone who, let's say I'm a professor, and public speaking is part of my job because I have to give lectures, but I can't give lectures unless I've got a couple of drinks in me and get a little bit juiced up, then that starts to become problematic. Or I'm canceling class, or I'm cutting lectures short because of my anxiety about going forward with stuff, then that starts to become problematic. Okay. We also see performance anxiety, people who, and this is strange, but people who maybe are musicians or work in theater or something like that, who specifically have anxiety about being evaluated in that situation, and when it starts to impact my opportunities to move forward, well, I would have to audition for this, but I'm not going to do that because someone would evaluate me, so I stop, right? Whether or not sort of most of us are willing to play trumpet in front of other people, probably not a big thing in my life, but if it is, and that's part of what I do, then that starts to become problematic. Other questions about social anxiety? Okay. Focus of fear here, remember, is social evaluation. If what I'm concerned or am afraid of happening is that someone will evaluate me or potentially evaluate me, this is what we're talking about in terms of social anxiety. Okay. All right. I'm going to switch things over, talk about panic a little bit. Okay. Panic is a tricky thing because panic attacks are something that happen a lot. Okay. Probably, I'm guessing, at least one person, probably more people in the audience today, you don't have to disclose, have probably over the course of their life at some time experienced a panic attack. Okay. Panic attack is a discrete period or a short period of intense apprehension, fearfulness, or terror associated by intense physiological symptoms. So what we see with panic attacks is we see things like I'm walking along and all of a sudden I'm having shortness of breath, heart palpitations, shaking, sweating, fear of going crazy, fear of dying, unsteadiness, things along these lines. Basically, my body just explodes. Okay? Now, this can happen a number of different ways. Sometimes these come out of the blue. Sometimes these are things that, so if I'm in a situation where I get really anxious and fearful and it works myself into a panic attack. But the issue with panic attack is these are relatively common. About a third of individuals will have a panic attack over the course of their lifetime. Okay? So just having a panic attack in and of itself isn't a disorder. Panic attacks are semi-normative. They end up with people in the hospital a lot of the time because if this happens and I don't expect it and know where it's coming from, I think I'm going to have a heart attack and die. So I go to the emergency room. In the emergency room, they go through and check me out, and they say there's nothing wrong with you. It's probably a panic attack. Okay? Where we start to get into panic disorder is where we have individuals who are experiencing recurrent and unexpected panic attacks that are accompanied by worry about the attacks and their consequence, and some maladaptive change in terms of behavior as a consequence of these attacks. Okay? So the key with panic disorder, if, let's say, Colin, what are you afraid of?
I used to be afraid of heights.
Okay, so let's say you're afraid of heights, right? And I take you to the Grand Canyon, right? and we're kind of looking over the edge, and we get a little bit too close, and you start to have an intense reaction, and all of a sudden you start to shake and sweat, your heart starts palpitating, you sort of get nausea, flip-flops, dizziness, kind of feel like you're dying, right? That's not an uncued panic attack. That means we got too close to something that you got afraid of, and you triggered a panic attack. Or let's say that you worry about school, okay? And you worry about school, and you put a lot of pressure on yourself about school, and you're just sitting there thinking about worrying a lot of what-ifs about school, and you worry yourself up into a point where you have a panic attack. Again, that's not an unexpected panic attack. You just sort of, in your head, worried about things until the point where you just pushed your body over the edge and exploded into a panic attack, okay? Unexpected panic attacks, uncued panic attacks, these are attacks that come out of nowhere, seeming from no reason at all, okay? So, Hannah, let's say you're just walking through Walmart, going through the grocery store, something like that, and all of a sudden, boom, for no reason at all, right? For just all of a sudden your heart starts racing, pounding out of your chest, feels like you're going to have a heart attack, you hyperventilate, you're dizzy, you can't stand, have to steady yourself, feel like you're going crazy, right? That's going to be an unexpected panic attack, okay? And what we see is for those individuals who will have these unexpected panic attacks, and they worry about the consequences and start to change their behavior, that's where we start to see a panic disorder, okay? So the focus of fear with panic disorder are these internal sensations. What we see with individuals with panic disorder will start to avoid any type of activity that starts to feel like some of those panic sensations. So the focus of fear, the thing that I'm most afraid of in panic disorder, are these physical sensations that I associate with panic, okay? So if I have unexpected panic attacks, and I'm afraid of having additional panic attacks, or what that means, what we can sometimes see people doing is I start to avoid things like exercise, right? I won't walk up steps, because if I walk up steps, that makes my heart rate increase, and that feels like a panic attack, and that freaks me out, so I don't do it, right? Maybe I don't drink coffee. I cut caffeine out, because if I have caffeine, it starts to get my body worked up. And if I do that, it feels like a panic attack, and so I avoid it, right? I might avoid sexual activity, right? That's going to get my body sort of worked up. I'm going to have some of these feelings of physiological activation. It's going to feel like a panic attack, so I can't do that, right? I don't go out without my cell phone, without my medications. These are things that I don't do because I might go out and I have a panic attack. I wouldn't have anything there, right? So these are the types of things that we see about in terms of maladaptive behaviors in individuals with panic disorder. And again, what we're afraid of are creating any type of physiological sensations that might feel like a panic symptom. And so I just avoid that altogether. Okay. So for panic disorder, lifetime prevalence is about about around 5%. And again, what we see here, Cameron, going to your previous question, we see panic disorder about twice as likely as women and men. And again, it's sort of just going into that increased risk for, or these sex differences in diagnoses of panic and depression and things like that, which again, we don't completely understand. Questions about panic disorder, what it is, and what the focus of fear is for panic. Okay. Now, what we see oftentimes with panic disorder is another disorder that we used to join them together. Now we've separated them. I don't know if I sort of necessarily like that, because these two things kind of come hand in hand. So let's say, Jonathan, let's say you suffer from panic attacks, unexpected panic attacks that come out of the blue for no reason at all. At any point in time, you could be paralyzed by a panic attack out there in the universe. As a consequence of that, what might you also start to do? What types of things might you start to avoid?
Any kind of activity involving going outside the house.
Yeah.
Kind of constricting myself to a singular area.
Yep. And this is what we see oftentimes with individuals who have panic disorder. The nature of their avoidance starts to extend to going out anywhere in any situation where I wouldn't be able to escape in the event of a panic attack or panic-like symptoms. Okay. And so what ends up happening is what I won't do then is I stop using public transportation, or I won't be in enclosed places, or I won't go to stores or be in crowds. I won't go into open places, because if I do, I'm going to have a panic attack and I'm going to be trapped and I can't escape and I can't get out. I might not drive. I might not go over bridges or things along those lines. And what we're talking about here is agoraphobia. Okay. Agoraphobia is the fear of having panic or panic-like symptoms in a situation where I won't be able to escape, and I won't be able to get any help. Okay. And so panic disorder, the focus of fear for panic disorder is these physical sensations. Agoraphobia, the focus of fear is being out and not being able to, sort of having these panic-like symptoms out where I'm not able to escape. And we see panic disorder and agoraphobia go hand in hand. Okay. You can have agoraphobia without panic disorder, but it's not common, right? Generally what we see is people have panic disorder, and as a consequence, a lot of their impairment comes from not wanting to go out in public. So maybe I don't drive, right? Or I do all my shopping at 2 a.m. I go to Walmart at 2 a.m. because then if I have a panic attack, the store is empty, I can escape and get out, versus during the day when it's crowded, right? Maybe I don't go outside. Maybe I have to have someone go with me. I don't go to crowds or go to football games, again, because I'm afraid I'm going to have a panic attack. Okay. And so we see panic, ago going hand in hand with this. You can have panic without ago. You can have ago without panic. But generally, we see these two things working together. Questions about...
Yeah. Is there defining the separation between the two? Like a threshold? Like if they go hand in hand, but they can work outside of each other?
Yeah. So I can have panic disorder without agoraphobia, right? So maybe I have panic disorder, but what I do is I have to 100% have my cell phone with me anytime I go, because I might have a panic attack. And so, or I need my medication, and if I don't have those things, I'm not going to go anywhere, right? Or maybe that I go through and I work at the top of an office building, but if the elevator is closed, I won't go up because I'm not going to walk up the steps, because that's going to give me a panic attack. So I'll just sit down in the lobby or just not go to work that day, right? Or I'm having trouble developing relationships because sexual activity I'm afraid that feels like panic attack to me, and so I don't go through and do that. So we can have panic disorder without agoraphobia. I'm still out doing things, right? I'm in public places. I'm just have panic, right? And sometimes people that have ago without panic. I've never actually had an unexpected panic attack, so I don't meet criteria for panic disorder. But I have panic-like symptoms, right, that have never got to the level of a panic attack, but they still freak me out. And so I don't stand in lines. I don't go to movie theaters. I don't go to crowded places because I'm afraid I might have some of these attacks. So I don't meet criteria for panic disorder because I've never had a panic attack and I'm not having unexpected panic attacks, but I'm still avoiding situations because I might have panic-like symptoms or acute attacks or things along these lines. So we can see these two happening separately, but generally what happens is I have unexpected panic attacks, and part of the impairment is associated with that is avoidance of situations. And so we tend to see the two going hand in hand. Okay. So got a couple questions here. One, didn't see, so can phobias or these anxiety disorders develop without personal experience? Absolutely. This idea is that the idea is that from a traditional standpoint, like I had a bad experience with dogs and then I have a dog phobia, or I had a bad experience with heights and then I have a height phobia. We actually see half or more people have never actually had a bad experience with sort of any of this stuff, right? And we don't know why it just kind of generates and sort of this fear develops in the absence of some sort of traumatic experience, right? So this can happen lots and lots of times, right? I don't have to be in a terrible car accident to develop a driving phobia. I might just be afraid and anxious about it, and sort of it develops on its own. So sometimes that can happen, but it doesn't have to. Also in terms of ago and panic, is it like fear? Yeah, like fear, anxiety, all this, again, if you go back to our initial slide, existing on a continuum. Sort of anxiety, kind of low-level stuff. Whatever I'm afraid of is off in the distance. Fear, intense fear, sort of it's right here on top of me. So thinking about thing on this whole, on this spectrum. And a question about, like, does paranoia play into this? Well, I don't know. It depends on what you call paranoia. From a clinical standpoint, paranoia means like I'm having delusions about things that aren't real. Here we've got concern, fear that's excessive given the situation, but it's more avoidance. So I probably wouldn't qualify this as paranoia from a clinical standpoint. Paranoia means something different, right? So you can say, oh, this person's paranoid that a dog's going to bite him. Like, well, yeah, they might be afraid that a dog's going to bite them, which is why they don't go around dogs. But paranoia is going to be a different thing. Okay, paranoia is the government's out to get me. Martians have planted something in my head. All of you are conspiring to get me fired. Like, that's the type of stuff that we would typically call paranoia. Okay. All right. So ago. Lifetime prevalence about 2.5%. So this is, again, sort of less common than the panic stuff. But again, these two things kind of go hand in hand. All right. Questions? All right. Yes, and they are always listening. If you have a cell phone on you, it's always listening to you at all points in times. You just have to. That's not paranoia. That's a real thing, right? All right, I'm going to switch over to OCD. Okay. Now, in our previous DSM, OCD was categorized as an anxiety disorder. Now it's housed under obsessive compulsive disorders, but there's still this big piece of anxiety component going on with this. So if we're talking about obsessive compulsive disorder, we're talking about individuals who struggle with problematic obsessions that then often lead to some type of compulsive behavior. Okay. Now, the important thing to remember here, obsessions and compulsions are two different things. Okay. Obsessions are thoughts and fears. Okay. Obsessions are the thinking component of OCD. Okay. So common obsessions that we see is that individuals having concerns or fear about contamination. Okay, I'm afraid that I'm going to go through and I'm going to touch this doorknob and get cancer, right? Or I'm going to, if I go through and I'm touching things out, now it's going to give me AIDS if I touch something out in the university or in the universe or something. I don't know. I'll just be contaminated and dirty if I touch things or come into contact with stuff, right? We see aggressive or horrific impulses as being another obsession. So the thought comes into my head. So let's say, Michael, you come over for dinner sometime and you're hanging out in my kitchen and I have a thought of grabbing the knife from the block and stabbing you, right? That's a thought that comes through my head. And that is so terrible. It comes from nowhere. I don't know where it came from, but that thought is sort of so upsetting to me that it starts to become sort of problematic because these thoughts come in that I'm going to do something. Okay. Symmetry. This is sort of less of a specific fear, but sort of more just needing to have things organized and in place and straight with the world. Doubting is a big thing. Okay. Did I do this? Did I do that? Did I shut off the iron? Did I lock the door? Did I shut my car off? These types of things. And then lastly, sexual imagery. This is going to be repeated and disturbing and unwanted sexual thoughts or images that pop into a person's head that start to cause a great deal of distress. Okay, so these are the obsessions. Compulsions, these are the behaviors, and oftentimes the compulsion is a reaction to the obsession. The compulsion is intended to neutralize whatever negative thought or obsession is going on, right? So what we see for contamination, we often see some washing stuff, okay? I'm afraid that I touched this thing and now I'm contaminated. Not just my hands are contaminated, maybe my whole body's contaminated. by touching this doorknob, I now have to take a shower all over. Even I just touched it with my fingers, now my whole body is contaminated. Or this thing touched that thing, and now the whole thing is contaminated. Part of OCD is this magical sort of the connections that people make don't always make sense. And so kind of this magical sort of thinking aspect of things is kind of a big piece of OCD. What we see sort of doubting associated with checking. I'm constantly late for work or class because I've got to go back to my house 3 times to make sure that I shut off my curling iron. As you can see, it's something that sort of gets me every time if I shut my curling iron off, right? But sort of, did I turn off the stove? Did I lock the house? Things along those lines. So going back through and checking. Then we see other things like counting, ritualized behavior. So I had the image of Michael stabbing Michael, and so what I need to do is I need to count backwards by 7s from 84 to 23 in order to make that go away. If I do that, that neutralizes the thought of me aggressing on Michael. But if I don't do that, then I don't know what's going to happen. It's just going to be something terrible, right? Or if I see a certain letter number sequence, unless I sort of tap or sort of do some type of ritualistic movement, it means that Cameron's going to sort of get in a car accident and die, right? Cameron's my brother, and sort of anytime this comes up, I have to do something to neutralize that thought. Otherwise, this thing is going to happen, okay? So we see a lot of ritualized behaviors, thoughts, sort of saying sort of things over in my mind over and over again, assuring symmetry. So I have to go through. I spend 2 hours a day arranging my house or my room or my living space so that everything is perfect and straight. Okay, so this is obsessions, compulsions, different things. The obsession is the thought. The compulsion is the behavior. And these obsessive thoughts are difficult to control. They're distressing. And what we see with the compulsions is sort of behavior that's going through to try and neutralize that obsession. Okay. Now, I can diagnose OCD based on obsessions or compulsions. They usually go hand in hand, but you just have to have one or the other in order to diagnose OCD. Okay. And here, the focus of fear for OCD is going to be the outcome of that obsessional thought. Okay. The focus of fear is that I'm going to be contaminated and get some terrible disease and die, right? Or the focus of my fear is that if I think that Cameron is going to get in a car accident and die, then that's going to happen unless I sort of go through and neutralize that in some way. The focus of fear is that my house is going to burn down because I didn't check the iron or the stove or something along those lines, right? The concern is that I'm actually going to perpetrate some type of aggression or sexual violence on somebody, even though I have no intention, would never ever do that. The thought came into my head, and that's what I'm afraid of doing, that I have to go through and engage in this ritualistic behavior to go through and neutralize that out. Okay. So what we see relatively with OCD, relatively equal distribution among across men and women. Lifetime prevalence of OCD about, it's not super, somewhere around 3%. Okay. The thing to remember with OCD is these thoughts, the obsessional thoughts, are not necessarily strange thoughts. These are things that tend to float through most of our heads on a regular basis, right? Like I'm walking through Walmart and I'm just walking past someone, into my head, I think about, like, what if I punched that person? Most of us would be like, that's a weird thing to think about. Like, I have no intention of doing that. That was just my brain just had a fire and I move about my day, right? But if I have OCD, I start to become very focused and upset with the content of that thought, what it means, and then start to perhaps engage in some sort of ritualistic behavior in order to neutralize that thing, okay? Again, so what we see is it's not necessarily the content of the thoughts that makes OCD. It's the intensity and duration, and my personal interpretation of these thoughts and what they mean that then continue on into some of these different cycles. Questions on OCD? Oh, so can previous traumas create OCD? That's a really good question, and it depends on what you mean. Sometimes people with PTSD are very, very hypervigilant about things and looking at potential danger. And if that hypervigilance starts to get really intense, maybe what happens is I won't go to bed until I've gone through and checked all my doors and windows to make sure everything's shut and locked. And I've got a whole routine where I circle my house 3 different times to double and triple check that everything's shut down. Okay, I wouldn't say that's OCD. That's hypervigilance associated with a post-traumatic stress disorder, not an OCD type of thing. Now, I can have OCD just because I go through and I check all the time, sort of separate from that. But again, so kind of from this classic idea is that some sort of trauma is at the root of all anxiety types of things. It's actually not much evidence. Certainly trauma can contribute to it, but that's not sort of doesn't appear to be the main driver. People just sort of kind of develop these things spontaneously on their own through genetic vulnerabilities. And then what we see is that people start to fall into patterns of avoidance, which then goes through and makes that anxiety more difficult to control. Other questions about OCD types of stuff? Okay. This is something people say, oh, I'm so OCD, I do X, Y, or Z. Well, maybe, but you're probably not, right? We all do. If we go through and take a look and you go through some of these things, most people will say, oh, yeah, sure, no, I think about that, or sort of, yeah, that happens sometimes, but I don't worry about it. It doesn't spend a whole lot of time in my day sort of going through and doing things. And so, again, sort of the kind of the thing that sets OCD as a diagnosis away from just regular sort of weird quirks that people have, because we all have our weird quirks. It's just that intensity and the duration and sort of the meaning and distress that's attached to things. All right. Cool. Going to finish up with post-traumatic stress disorder. Okay. Again, post-traumatic stress disorder originally housed under anxiety and anxiety-related disorder. It's kind of moved off into a trauma-related disorder section. But again, this anxiety reaction, a big piece of PTSD and how we understand the maintenance of things. So if we're talking about PTSD, this is identified as a collection of symptoms marked by some distressing re-experiencing of some traumatic event. Okay. Something has happened in my past and it's very upsetting to me. And when I think about it, or if I see things that remind me of it, those thoughts create a considerable level of distress and subsequent avoidance. So what I do is I avoid things that might remind me of that event. I do things to keep my mind busy so that I don't have thoughts of that event. I might see changes in the way I think about things, the way I view things, the way I experience certain types of emotions. And I might start to see changes in sort of just general activation, hypervigilance, sleep, concentration, things along these lines. Okay. Focus of the fear for post-traumatic stress disorder is these traumatic memories, right? These are the things that I get. I will go out of my way. My number one goal is to avoid having thoughts or images or experiencing thoughts or images of this thing that's happened in the past, this traumatic event. Okay. Now the question is, a big question in this area is what is trauma? How do we identify or qualify trauma? Okay. Now trauma is one of these words that we sort of use quite regularly within our sort of general vocabulary, right? Like, oh, I don't know. Did anybody watch that Bills game on Saturday? Anybody see what happened there? Last minute, Hail Mary. Like 11 seconds left in the game. It was a 1 in a million catch. He came back. I was traumatized by that. Crushed, right? But I wasn't really traumatized by that. That was a disappointing thing. I was angry about it, sort of incredulous. It wasn't a trauma, okay? When we're talking about trauma, we're talking about exposure to actual or threatened death, injury, or sexual violence. And we can experience this directly. Sometimes it's things that we witness. Or in certain situations, we can, if we're learning about something or being repeatedly exposed to details of this stuff, something that would qualify as trauma. Okay. And so again, the idea here is that I've had something happen to me, and these thoughts and images of this thing that happened, I'm not able to move past. They continue to cause me a great deal of distress. They're starting to disrupt my life in a number of different ways, resulting in functional impairment in different domains. So the question is does trauma cause PTSD? Okay. Does a traumatic event, does this experience cause sort of my symptoms, right? And this is a tricky question, right? If we look at good, at least for the US, epidemiological research, probably, if we're taking a pretty strict definition of trauma, about close to 2/3 of men and at least half of women reporting at least one traumatic event over their course of their lifetime, okay? Generally, it's more. Trauma is super common, happens all the time, a lot more than we would like to admit, but this is going on, right? But when we look at lifetime prevalence of PTSD, we see lifetime prevalence of PTSD sort of around 8%. Okay, what does this suggest to us?
PTSD isn't a necessary result of trauma.
Yeah, perfect, Hannah. Yeah, if trauma caused PTSD, I would expect about over half of the public to be walking around with PTSD diagnoses, but we don't, right? We are, as human beings, incredibly resilient. Like, the amount of damage that we can take and continue on is really, really impressive. But for some people, and we don't understand exactly why, have a hard time sort of moving on, and it depends on the type of trauma. Not all traumas are created equal, right? If I experience a sexual assault, the likelihood of me developing chronic symptoms is much, much higher than if I, say, experience some sort of natural disaster or something along those lines, right? Or if I am involved in a serious car accident, much more likely for me to experience chronic symptoms than if I see a bad car accident, okay? But what we know is that trauma probably doesn't cause PTSD, but and there are going to be certain types of things, like we've talked about all semester, that make some people more vulnerable to developing chronic symptoms. But what we do see is, again, that natural recovery response, right? That natural resilience that we see in people, right? Immediately after something terrible happens, almost everybody's going to have an intense reaction, right? If I was raped yesterday and I'm upset about that, that makes some sense. That makes me a human being, right? That's not a disorder, right? But if I go through and I continue on, right, for months and years, and it's sort of several years down the road, and I'm still having trouble with memories and nightmares and avoiding things that might be related to, that might institute or trigger memories of my sexual assault, and I can't go out and do things, and I have a hard time building relationships, and I'm super hypervigilant, and I can't concentrate and sleep. That's what we're talking about in terms of some of these symptoms, right? And what we know is that the intensity of the trauma and the frequency of it, right? So maybe I have one event and I shake it off and I'm doing all right. But then something else happens. And then something else happens and something else happens. We get kind of this piling on effect that looks like it starts to erode sort of my ability to bounce back. And so this is why we see an association with increasing levels of trauma, increasing the likelihood of developing some sort of chronic symptoms as we continue on. Okay. So in terms of does trauma cause PTSD? Probably not. It's necessary, but it's not sufficient. What we see is the vast majority of people return normal and are doing okay. But for a small subset of individuals, likely to go on and have some difficulties as we move forward. And that's due to genetic factors, environmental factors, lots of different things, just like everything else we've talked about up to this point. All right. So again, focus of fear with post-traumatic stress disorder is going to be these trauma memories. All right. So the thing that's important to remember is we're going through and you're thinking about trying to keep this stuff straight in your mind, thinking about remembering the focus of the fear for each one of these, because it starts to make a difference. All right. So let's say, Brooke, I will only go to Walmart at 2 a.m. to do my shopping, right? And this is causing a lot of disruptions in my life. What type of what diagnosis do I have?
Would it be that agoraphobia? I'm probably butchering that because you won't go to the store at 2 a.m. Or what is it? Panic disorder.
Okay. Could be ago. Could be panic. What else could it be? Anyone?
Social phobia.
Could be social phobia, sure. What else could it be?
PTSD.
Could be PTSD, absolutely. What else could it be? We don't know.
Specific.
Yeah, it could be a specific phobia. I got a specific phobia of contamination, or a specific phobia of illness, sort of contracting an illness, right? Could be anything, right? So just knowing that I avoid something doesn't tell me anything unless I know specifically what's going on, right? So you're absolutely right, Brooke. So if I only go to Walmart at 2 a.m. to do my groceries, so my thought immediately goes to AGO, right? Because that's what we often see, individuals with panic and agoraphobia, right? Because that way the store is empty, and if I have a panic attack, I can split, I can escape and get myself safe, right? But maybe I have social phobia. Maybe I have just really intense social anxiety, right? And my focus, my fear, the reason I go to Walmart at 2 a.m. is because there's no one else around. So if I do something stupid or something, there's only so many people to evaluate my behavior, right? And so it's easier for me to do that than when sort of there's lots of people around, right? Or maybe I have PTSD, right? Maybe I'm sort of this hypervigilance for I need to be able to keep my eye on everybody at all times, and I can't when the store's crowded, but when it's empty, I feel safer, and I can go through and sort of handle this better then, right? Or maybe I have a specific phobia of contracting an illness, right? I feel like the store is cleaner, and there's not people around to give me COVID or sort of whatever thing that I'm afraid I might catch from people with sniffles and things like that, right? Maybe it's OCD, right? Something about sort of like at the middle of the night, there's no things to trigger obsessive thoughts that I then have to engage in compulsions, right? So in any situation, and so this is a big, big issue with diagnostics, needing to know what the focus of fear is for these things, what's behind the avoidance. And once we know that, then we can start to sort of say, okay, this looks like this, that, or the other thing. Okay, so as you're working through this stuff, just make sure focusing on identifying focus of fear with each one of these. And if you do that, you'll be pretty good to go. So make sure to go through, take a look at lecture summary slides, comprehension check slides. We're going to get into depression today, but with 3 minutes left, I don't know that makes sense. We'll just pick up. We'll pick up depression on Friday. So any questions people have about any of the anxiety disorders, any of the stuff that we covered there?
Yeah, I had a question about PTSD.
Yeah.
So like, say like a veteran comes home from war, and then like, how long does it take to like but like diagnose PTSD? Because like, obviously they've been at war for a while, and so it's like probably repeated trauma. Do you see what I'm trying to say?
Yeah, absolutely. And that's a great question, Cameron. So, how long is the right amount of time for someone to get over something, right?
Yeah, exactly.
Yeah, that's a tough question. It's also an issue that comes up in trying to identify people's stuff with grief, right? Like, let's say I lose a family member due to an accident or due to a health issue or things like that. How long should I be upset about that? I can't put a number on that and can't say, right? But what we would say is after a certain point, right? So if someone came in and they just lost a family member 2 weeks ago or a month ago, I'm probably not going to diagnose them with depression, because probably what we're saying is better conceptualize the grief reaction, right? And so really what we start to see is impact on impairment a lot, right? So what we know is we get this natural resilience or this natural recovery curve, and a lot of people make good arguments that PTSD is a disorder of non-recovery as opposed to something that happens. So most of us continue down, we're just doing all right, and then we kind of get sort of back to normal, right?
Yeah.
And the idea is that for some individuals, they get stuck in that trajectory. And I just stop sort of that recovery just stops somewhere where sort of the majority of folks are going to continue on. I just get kind of stuck here, and then I just kind of float along. What we see is, if someone's had symptoms for 6 months or so, or sort of longer, the likelihood that those are just probably going to go away on their own starts to decrease the longer they continue on. Now, technically, I can't diagnose PTSD. It is a month, right? So I can diagnose PTSD after a month. If something's happened and you're meeting diagnostic criteria a month later, I can diagnose PTSD. But I can do that. But if I probably, let's say you're in a bad car accident and a month out, you're still having nightmares about this. When it comes up, you get pretty upset about it. There are certain types of things that will cue up memories. You avoid driving, and you for sure don't want to be a passenger. You sort of noticing you're changing the way you're thinking and feeling about things, having trouble with experiencing emotion. I can go through and diagnose you with PTSD at that point in time. But if I were to follow you up, say 6 months later, there's a pretty good chance that you're going to be sort of back down, you exhibit that natural recovery, right? But if it's 2 years out and you're still at that same place, probably those symptoms in the absence of treatment are probably going to continue on. That fear of driving and some of that stuff probably isn't going to go away on its own after that point. So, like anything else, there's no hard cut point. It's kind of a continuum. But the longer things kind of continue on, the less likely it's probably going to go away on its own.
Yeah. Cool. Thank you.
No worries. Other questions on this stuff?
So, say for like my grandpa, he came back from Vietnam, and his got like better after like a while, and then he just like stopped talking about it, and then he like finally just recently, he's 72 now, and he got drafted when he was 18, and he just like a couple months ago, he like told my mom some of the stories, and now he says like he's getting it back again.
Yeah.
So can you like get it on and off like that?
Yeah, like anything else, right? So we can see kind of a waxing and waning trajectory of some of these symptoms. And this is something you see, it's a question in PTSD, this idea of delayed onset PTSD, right? This idea that, hey, this thing happens and I'm fine until, 10 years down the road, and all of a sudden I explode in terms of a post-traumatic stress disorder diagnosis. I'm not saying that can never happen. I'm saying it's probably pretty unlikely, right? Probably and sort of in working with veterans, what we often see, particularly with some of those older guys, right, is I come back, sort of say World War II type of thing. I come back, and what I do is I throw myself into work, family life, sort of things along these lines, right? And so what we see with PTSD is oftentimes that's an avoidance strategy, because if I'm busy with work, if I'm doing things, if I have hobbies, if my schedule's constantly stacked with stuff, it doesn't give me time to think about sort of things that happened in my past, right? And that can be fine. I can be quite functional for an extended period of time, right? But the thing is that if I've just got really good at avoiding, it's not that it's not there. It's just that I'm keeping it pushed down. I'm pretty efficient at that, right? But maybe I transition into a retirement, and now all of a sudden, all those things that I used to avoid thoughts and feelings are not there anymore. And that stuff that was there the whole time then just starts to kind of pop up, right? That's probably sort of maybe a better explanation for some of that delayed onset stuff. Not saying that it couldn't happen, but the idea that, it's just going along, and then I'm fine, and then all of a sudden it explodes up. Starts to get into some more mystical, dynamic types of conceptualizations that don't have a lot of empirical support.
Would you say that PTSD could like cause depression or be a factor in people
absolutely.
becoming really depressed?
Yeah, absolutely. And vice versa, right? If I struggle with a long-standing history of depression, probably if something terrible happens to me, I'm going to be more vulnerable for developing chronic symptoms of chronic trauma symptoms. But other way around too. Maybe I'm fine, but this thing happens, and so I'm experiencing some post-traumatic stress disorder. But periodically, I fall into episodes of depression where I'm not able to get out of bed. I sort of have fluctuations in sleep, appetite, thoughts of worthlessness, and things along those lines. So yeah, all this stuff goes hand in hand. It's in clinical setting. It's often sort of rare to see someone just come in with just one thing.
Yeah, I was just thinking like, if you have PTSD of some type of event and people can't really relate to it or anything, might make you feel really alone or like in it by yourself.
Mm-hmm.
That's why I was thinking it would make you be like depressed.
Yep. And that's some of that interpersonal difficulties and having a hard time connecting with other people is kind of central to some of those trauma reactions, which can then sort of lead into sort of other types of difficulties. Yeah. Anything else?
Dr. Clapp, kind of going off what someone else was talking about earlier, how the PTSD came back after a while. Is that along the lines of like how we were talking about conditioning, like extinction, renewal, recovery, and all that, or is that totally separate?
Oh no, that's brilliant, Jonathan. Yeah, I mean that's part of the idea that, and so one of the things that'll happen too is so for our treatment for all of these disorders that we've talked about, our best evidence-based treatments are mostly exposure-based stuff or have some element of exposure, right? So what we do is we go through and have you work in a safe and controlled environment with that feared object or stimulus in a way so that starts to reduce and we get some habituation of that anxiety response. But what can happen is, so we get you down to a spot where you're doing pretty good. Sometimes that stuff will pop back up again, right? The idea behind sort of our good evidence-based psychosocial treatments is if that happens, you can identify it and know what it is and know, hey, these are the things I need to do to sort of keep and sort of manage that and push that back down. So, some of that renewal recovery types of thing is part of our explanations for why some of this stuff might start to pop back up, even if we get it down to a good level. And then also external stress, right? Things are easy to deal with when I'm not dealing with a lot of external stress. But when I do have to deal with external stress, things get harder. Some of that stuff can start to exacerbate, so kick things back up again. Anything else?
From a diagnostic standpoint, having a bunch of comorbid disorders, what does that do to the diagnostic process? Does that make it easier, harder? How does that influence it?
Yeah, it starts to become tricky a little bit. And so, again, good diagnostic work involves kind of trying to tease this apart, right? So if someone comes in and they're sort of asking about some trauma stuff, right? But they're reporting a lot of depression. What is important is that I sort of identify depression as depression and not call the same symptoms of depression the same symptoms of PTSD and sort of overlap on the two, right? Similar to our example, like I don't go to Walmart, right? Like, well, are you scared of social situations? Yeah. And then so really what we're working with is a social anxiety disorder. But I decide because I'm not being careful to also diagnose you with panic and ago when that's not necessary. The social accounts for everything. But if I'm just checking boxes, if I'm asking you questions and you just say yeah to stuff, yeah, I'm going to diagnose you with like 7 different things when really it's just one thing, right, that's going on. So the diagnostic stuff is hard to do, and it takes a lot of time, which is why I get aggravated when someone meets with some care provider and I talks with them for 10 minutes and then I come out with a diagnosis of bipolar disorder or something like that. That's super hard to diagnose well, and some things have carried some important considerations, right? So one, thinking about that, making sure that if I do have comorbid disorders, I actually do have comorbid disorders. But then number 2 is thinking about from a conceptual standpoint, how does one thing lead to the next, right? So maybe I have, just use social anxiety because it's easy. Maybe I have social anxiety and that's the thing that's really caused my problem, right? But I'm also maybe drinking a little too much and I'm struggling with some difficulties with depression, right? And I meet criteria for both of those things, but really what it sounds like when I functionally kind of tie everything together, looks like I primarily have social anxiety, right? But I'm drinking a lot to try and impact to reduce the social anxiety. And sort of I'm depressed because I don't have a social network. I'm not getting out and doing engaging activities because I can't because I'm avoiding social situations. And so what I would probably say there is, hey, if we probably treat this social anxiety, we get that taken care of, bring that down, the drinking and the depression probably come down with it as well, right? But what you can get is someone say, oh, hey, you drink too much, we're going to target that. Well, maybe, but it might be hard. It's going to be hard to sort of get you to stop drinking as much if that's your crutch for the social anxiety, right? So thinking about how this stuff fits together, which takes a lot of time and sort of involves sort of talking with people and sort of knowing how things get put together, which is harder to do in a 20-minute session with your GP or something along those lines. Anything else?
Just for study's sake, Dr. Clapp, will
Yeah.
we be skipping over Module 43 and going straight to 44?
Oh, I don't know. What's Module 43?
43 is schizophrenia and other disorders?
Oh, yeah. We've got other stuff to talk about, so if it's not in this syllabus, you don't have to worry about it. Sound all right?
I have a question.
Yep.
It's slightly irrelevant, but will we be covering autism spectrum disorder at any point?
We won't be covering autism spectrum disorder sort of in this class. Again, sort of my sort of thought was to just cover kind of the big ones. They cover anxiety, depression, sort of stuff like that, because that's the stuff that is sort of most common. Then talk about interventions and how we tell the difference between a good intervention and stuff that works and stuff that might sound nice but sort of maybe doesn't. But if you're interested in some of these, learning more about sort of some of these different types of conditions, abnormal psychology is a fantastic course to take. Also, sort of there's developmental psychology, intellectual disability courses that sort of start to capture some of those other types of things. All brilliant, amazing classes taught through our department, which would encourage you to take a look at if that sort of helps move you forward in whatever your career plan is.
Sounds good.
Yeah. Anything else? All right. You all are champions. Thanks for hanging in there. Enjoy the rest of your day, and we'll catch up with you all on Friday. All right. We'll see you, folks.